then I think things become much more easy. The first and foremost thing what an examiner will expect from you is, have a good flow chart. It's very, very important. Nobody is interested in long stories which has no meaning. I'm sure the earlier speakers also mentioned the same thing. I will also say the same thing. I will tell you, construct yourself. That itself speaks volumes. As a student, I was not told, so I was a storyteller. I used to go writing stories after stories, and I sometimes got less marks. Of course, you can't expect the marks to be like mathematics because there's no end point here. In science, you get a grade, you get a percentile, you get a percentage. You don't get 100%, right? That's fair enough. But I wanted to get the workflow. So whenever you get a paper, the first thing is, what? I want you to read the paper well. Read it twice. Be like a carpenter. We are referred to as barbers or carpenters because of our tools that we use, right? But what does a carpenter do? He will measure it twice, but only cut once. That's exactly what I want to do. I want you to read the paper twice. Write once, but read it twice. Because sometimes in that mood that you're in, you may not write it well because you read it wrong. The question that it needs to be written, so many times when we ask a viva question, when we ask an oral question, or it may MCQ, or a short note, or even a long question, the gist of the matter is lost. So try and understand what the examiner has asked you or what the paper demands. That's all. And write to the point. Believe me, every examiner will give you the same amount of mark, be it a smaller paper or a longer paper. If you have covered all the points, like you have good flow charts, you have good pictures, good diagrams, which are, diagrams are well, put up, very self-explanatory, they're very, very legible, with a good highlighter. These are all very, 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 very important things. So I want you all to do this. When you read the paper, I said read twice. Every one of us know, including us, that all the questions we may not be good at all the time. There are some things that are your favorite, some things are less favorite, and some things are least. Whatever is your best, write them first. Because the question that you don't know well, if you waste time, and the question that you know best, you'll not get maximum marks because you didn't have time. So write the first round with the best questions you know. And if it flows the flow chart of the paper, excellent. If not, write again what you know best, go back, see second best, and then the things that you don't know. Because the things that you don't know won't attract much marks anyways, right? So that's okay. But at least where you can score, get them first. That's what I want you all to do. So try and get this habit in yourself, and do not waste times on those that you don't know, right? So we will do one thing. We will do a skeletal for this particular topic. So if you see this biomechanical preparation, I want all of you, I'm sure I'm not going to give you notes of each topic. I'm going to give you a lot of clinical pictures and videos and some demonstrations maybe, but I'll give you a flow chart. Suppose a question comes on BMP. What will you write? In fact, it's not called BMP anymore. It's called cleaning and shaping. Sometimes there's shaping and cleaning because you have to shape first and then clean next. We'll talk about all that things. But the most important thing what you need to understand is structure your answer, for which, for me, it starts from introduction to conclusion, whatever the headings that can come. So I was just sitting on this question and I said, let me write my way, So I'm not going to give you other ways because I'm sure all teachers from your respective colleges have given you good notes. You can also borrow notes from each other's colleges, follow them, read them, get it from any literature that you can get. But I want you all to understand how to write a paper. I would have written an introduction that is like you're introducing a subject. You need to always do that. You need to introduce everything first. And then you write why. Every study or every question will have aims and objectives. Aim is just one most of the time. Objectives are many. What is the reason behind the question being asked? What do I need to write about that question? And then you can go into the principles for this topic, of course. Then you can go into the terminologies. You can go into the motions of instrumentation. You can go into the working length determination. You could go into techniques and maybe conclude it. In some other classification and some other question, you may have a classification to write, advantages, disadvantages to write, pros and cons to write, whatever it may be. So when you get a question like this is what I would construct. This is my constructing, because for me, it's all about readership. I want to read it well. If I've seen that the student or the participant has written the flow chart so beautifully, has given me beautiful pictures, has labeled them well, have put a good sketch of the flow chart, I know he knows the answer well. Even though he has not got enough time, I will be for it. It's that way, I'm sure all the speakers, the examiners will think the same way. So please try and understand this much. Now, when it comes to introduction, what do you want to write about introduction? In introduction, of course, what is BMP? Why was it called BMP? First is what is called chemomechanical. There's a lot of chemicals involved, then mechanical happened. Then it became biomechanical because biological aspect came into the mechanical aspect. Today they say, let's not make it as only biomechanics. Let's call it as cleaning and shaping. Actually, truly speaking, shaping and cleaning, but if you don't shape, you cannot clean. So the whole concept has changed. These are all newer words that's been mixed up and used up. You can call it a misnomer. You can call it as the right word to be used. That's your wish. First thing is about introduction. Give it in a small paragraph, apt and brief. Don't make storytelling to the point that if you don't know an answer, it's a different thing. But if you know an answer, I want you to give the good story to the point. Second point will be objectives. When you talk of objectives, you need to say, why was it asked? What are the objectives of cleaning and shaping, or shaping rather? There are two things. One is mechanical, one is biological. What are the mechanical objectives? That's what shape it demands. A smooth flowing curve, rounded angles, a flare on different levels, keeping the apical diameter as small as practical. You don't disturb it. Follow the inner and the outer, respecting diameters and the walls and the flow of the root. These are all the mechanical objectives Herbert Schilder gave us, right? Now there are something called as biological objectives. Why do you have to enlarge the root canal? It is true that when you clean with, say, hypochlorite or with any other chemicals, it removes a lot of bacteria from the canal. But remember one thing, for your needle to go inside there, for you to irrigate that place, you have to shape, otherwise the needles don't go. The thinnest needle is about 30 gauge. And the 30 gauge needle has to go in to the deepest portion, that is the apical end. In the roots, you have three ends, right? You have the coronal end, you have the middle, and you have the apical end. At the apical end, if the needle has to reach there, you have to prepare the end to a good diameter. So now you understand there are three things to remember in this root canal. One is called the length. That's called the working length. Will come later. You have no choice. You have to enlarge till where it is. You can't be short. You can't be beyond. Second is called a diameter. End of the root has got an exit. That's called the minor diameter for us. But now it's infected. So we need to enlarge it to a certain diameter. If you have read Grossman's principle, he said, let us enlarge the diameter to about 3 sizes. Now, this was just a concept. It's not a must now. You may do it 3 times, you may do it 2 times, you may do it 5 times. You clinically decide that. But you need to understand what it means. So you're enlarging the diameter a few times more, only because to get a biological concept, which means you want to bring the dentine, which is infected on the inner wall of the root canal, to an area where it's non-infected as much as possible. That's why you enlarge it, say, the initial apical file to a master apical file. That's 3 sizes. Initial apical file is the first file that binds the root canal from the entry point till the very end, till the prescribed point. That's a snugly fitting file that goes to the full length. It's called the IAF. It's an initial apical file. Now, old literature demands that you have to do it 3 sizes more. So if the 10 number file, a K file, is binding tightly, we want you to enlarge till 15, 20, and say 25. So you'll stop at 25. Fair enough. In the newer concept, the whole thing has changed because argument is very simple. They say, suppose I enlarge till 25, what guarantee do I have I get clean canals? Or sometimes I don't need 25. I can be lesser than that and still have clean canals. Both arguments are correct. It also depends on is the tooth vital or non-vital, infected or non-infected. So that theory is a separate topic. We're not going there. I just thought I'll give you a little clinical perspective why these two objectives existed, a mechanical and a biological. Biological because it is not only because of irrigation that the bacteria go out. When you do a cleaning and shaping, mainly shaping, a good amount of bacteria gets out because of the dentine debris that gets cut and you're washing it out. So mechanical is still there, but it's called a shaping. That's what you should understand. So then comes principles. What are the different principles you want to think about? We'll just stick to Cohen. There's crown preparation, root preparation. Root preparation was called as radicular cavity preparation. They spoke about terminologies. Now, different terminologies have been used. Now, we'll just cover a few of them. I just picked up some clinical slides to explain them better, like a pre-curved filing, maybe apical patency, a glide path, a recapitulation. These are the words I saw in the books. I know I'm speaking to undergraduate students. I know I'm speaking to young minds. But if you understand this well, I think and if these points are kept in your mind, constructing a paper, writing an answer should not be a difficult thing because this is absolute a clinical thing. If you go into some topics which are non-clinical, where there are formulas, I know you may have to mug up, you may have to by heart, you may have to study it a very, very different way. Okay. So the next point, we'll come to these points one by one in a clinical example a little later. Motions. When you talk of motions, you need to understand again, what are the motions of instrumentation? The oldest motion was called reaming. You type into Google, type into any, dictionary, ask what is reaming. One of the meanings will be you're reaming a root canal space. That's how close reaming was mentioned. Basically, you're drilling into the space to remove the dentine. Okay. Filing. Filing is what you're going in and out to again cut dentine. Then it came circumferential filing. Then there is watch winding. There is balance force, envelope of motion, whatnot. We'll see if time permits, we'll cover them. Working length is another important topic because you can only work till where you can go. Like I said, this first it was length, then was diameter. Third is known as taper. Taper is less important when it comes to length, diameter, and taper. Length, you have no choice. Diameter, you have less choice. Taper, you have all the choice. Do you want to make it a big flare? Do you want to make it less flare? Choice is yours. Follow whichever concept you want. Everything works. And finally, when you've written this paper, you need to conclude the paper saying that, yes, the justification of these explanations was these. That's how you close the paper. That's a concluding remark. So always an opening statement and a closing statement is very important in any construction. It might be a write-up, it might be a speech, it might be anything that you think of. So start making it as a habit in life to make this as a skeleton, as a structure, as your flow chart for anything that you want to do. It makes your life more disciplined, more organized. So for biomechanical preparations, I thought of these. You can still add more, I don't mind. But again, you think, what was the question? Was it a short question? Was it a viva question where only one point is picked up? Or is it a long question where possibly you have to write an elaborate thing? Then I may add some more in this. I've not gone into everything, like recent advances or anything that can come. So speaking of biomechanical preparation or cleaning and shaping, with respect to shaping, there are a few points that are mentioned here. We'll take up them. It's like glide path. So if you see here, what do you mean by glide path? Again, as undergraduate students, don't get confused. Don't have to worry about all this much. But glide path was a concept. You know why it came? It came because X-rays are 2D. The radiograph that you take are 2D pictures. And tooth is a 3D. So what we need is, we need to work in a 3 dimension or a third dimension, which we cannot see. So to get the glide path, when you make a radiograph, you can see the right and the left, that is mesial and the distal. You can see the down and the top, that is the crown and the root. But you cannot see the in and the out. Okay, that's the third dimension, which means you cannot see the cheek and the palate. That's the third dimension, for which sometimes we need CBCT, like a scan, like a 3D. I'm not going there. What you need to know simple is, what is a glide path? Glide path is nothing but you need a hand file which will travel from the entry point of the access cavity till the end of the root canal in a smooth fashion, repeatedly, passively, systematically, every time. And that's what is needed. And preferably a glide path file should be a stainless steel file because I want a reproducible glide path. I want to register the impression of the canal. Because when you take the file out, when it curves palatally, when it curves buccally, the file when you take out, it shows me the direction of curvature, which never comes on a 2D, never comes on an X-ray, never comes on a radiograph. That's what glide path will teach you. So what you need simplest is the smallest file. When I say smallest, of course, you will argue and tell, yeah, 6 is small, 8 is small. Correct, it's small. But the standard file that 10 number offers you with resistance, the others don't. So I need a 10 number file to go up to where you can go, if possible, to the full length of the root end. That's here. That is known as a full glide path, a passive glide path. It has to be a super loose number 10 file. That's how it is. Now, if that you can get, I think the root canal becomes easy because you know the path, you know the direction of its travel. It might be a short canal, long canal, curved canal, narrow canal, wide canal, straight, anyway, or a block canal. So you know, you get an idea of how to work. So they are called scouter files, like the number 10 file or the small files are called scouter files. Like I said, it's for undergraduate I'm talking, so I don't want you all to get worked up with all these references. But these are the people who develop these concepts. The good clinicians, Richard Munz or your Cliff Ruddle or John West, they are the people. So I'm not going to read the slides here, but what you need to understand is you need different types of files for different cases. Now, every root canal may not be simple. Some may be simple, some may be a little difficult, some may be not very, very difficult. So we'll classify them as simple, not so simple, or not at all simple. So different types of files to get the path inside. So these are hand files. In the earlier days, we did root canals with only hand files. We put a 10 till the file becomes loose. We took it out, washed it, put a 15, again did it, put a 20, again did. We went on doing it till say 40 or a 50 or a 60 number size. 60 is nothing but 0.60, the 60 size apical diameter, a 0.6 cross-sectional diameter at the apex. But these were all hand files called 2% files. Leave it at that. I'm just trying to give you a concept. Because I told you a steel, you can pre-curve the file. So when it's a hand file, you don't write as a night type, please write as a steel file. Even though you get night type, that's not for routine endodontics, it's for something else. Okay. So you pre-curve the stainless steel file and we'll use it in the root canal. There are 10 number files you can pre-curve like a hockey stick pen. And just for you all to see a small video, you're pre-curving it and then introducing the root canal to negotiate the root canal. Because it may go into a strong lateral canal like the way it's going here now. You see here, it can go into the nooks and the crannies of the root canal system, like the one that's there. It can go into the hideouts, it can dislodge tissue tags, many things can happen. So this is nothing but a recapitulation file. In our times, we are told recapitulation is a big word. For us, recapitulation was a file smaller than the bigger file. It was not told it is 10 number file. It can be any smaller file than the last file. So even now we follow the same concept. But what we do is we put a smaller file before the larger file and after the larger file also. And for me, there's always a 10 number file, a stainless steel file, a pre-curved file where I can go to full length and try and tease and tickle the canal. Because you dislodge the tissue tags and try and take them out. You wash them nicely. So that's called a pre-curve filing and tick. So you will have to know these motions. In the books it was given, I saw this, that's why I put them here. You have a motion called watch winding. What does it mean? Olden days, we had this watch where you used to give a twist, it used to go clockwise and come back that way. It's a 30 degrees turn, forward, backward motion. So we see this video now, see this. The stopper is facing you, you're only teasing and tickling the root canal to take it to full length. So you're just doing that much. So that's known as a watch winding motion. So I want you all to understand to go till there as a watch winding motion. So slowly start teasing and tickling it that way. 30 degrees to the clockwise and 30 degrees to the counterclockwise. Now You have something known as a balance force motion. In a balance force, you do the same thing more. You do 90, give it an apical push, and then pull it back. So that's how it goes in a balance force motion. So 90 degrees, apical push, 270 reverse, and then you pull it out. Wash it nicely, again introduce a file. Cutting is 90 degrees because all files only cut forward motion. Remember this much. Let it be hand, let it be rotary, except on a reciprocation motion, which is a different concept. And then you have another motion called as envelope of motion, or okay, we'll call it push pull. Push pull is nothing but a short strokes of push pull that you do till you go there. This is not the best motion to do in a root canal, especially when you're at the apex. I don't want you to push things beyond apex. I want you all to be very, very, very clever and clear to do that. If you understand these concepts, writing a paper becomes very, very easy. Just try and correlate it there. And then you have something called as envelope of motion. I didn't know if this was important for an undergraduate, but this is how you do it. You turn the file, a pre-curved file at the belly of the file, so that you enlarge the canal above a canal if it's a block canal, so that you prepare it well. So this is how it goes. See this? There is a file, there is a gradual curve, and in between, in the belly of the file, there's a curve, and that is touching the wall to enlarge the canal bigger. So you should understand few motions of instrumentation, because you may get a question. I've seen in one of the universities, motions of instrumentation was a question. So you write all the motions of instrumentation. So if you write this, I'm sure any examiner will like it, because this is something that I expect from a postgraduate, not from an undergraduate maybe. So envelope of motion. Just to give you a clinical example, it's flowing in this pendulous motion. The tip is not cutting and the top is not cutting. What's working is in the center. So suppose this case was referred to me from somebody. It's got blocked. Canal is not blocked by nature. Believe me, it's man-made. So the earlier dentists used larger files in a quicker motion maybe and plugged it, and the debris is blocked. Now we need to clear it. So what we do is we use the smaller files with some chemicals like EDTA and soften it and try and get to length. And then we remove. That's when this envelope of motion will help you. And we worked on that canal there, and then you went that way. So it's filled up now. See, the root canals are filled. The white things that you see are a complete root canal that has been filled. We kept some Teflon, put some glass ionomer, referred this case back to the doctor who wants to do the next job. Like you saw a glide path file, initially they were only hand files. You also have now something known as a rotary file. This is a rotary file. It's a glide path file. See, I'm going into the root canal and coming out. They're all worked on the microscope with a lot of wet clinical condition. You see the chamber? It's flooded. It's flooded with a lot of chemical. It mostly is hypochlorite, sometimes a mix of hypochlorite and EDTA. Why? Because I want lubrication and I want many other advantages what EDTA provides us, right? So you're going in and out, never a dry canal. This is a rotary glide path file. So we'll leave glide path there. We finished pre-curve filing. I only want to speak about patency filing. You know what patency means? It's nothing but purposeful placement of an 8 or a 10 or a 15 number file little more than the tooth length. That is the apical diameter, minor diameter, not the major diameter. So we go there and you see at the end, that's the end, and you go little beyond. Basically, I'm trying to clear the debris. Most of the times we work a lot and it's done well, preparations are very good, but unfortunately it's not cleared well. So that's when you need something to clear. So try and clear it this way. So that's a more important thing. So this is apical clearing of the debris, where you're peeping in and peeping out, not too much out of the root, in the root between the major and the minor diameter, just to clear the debris. It's one of the important factors, because any preparation, let it be amalgam, let it be composite, let it be root canal, toileting of the cavity is the last principle. This, what I'm speaking, is called toileting of the cavity. So glide path is this way. You know what we did here? We actually took an extracted tooth, pushed the file to full length, which you'll not do in the normal tooth, held it there for a minute, and you turn the file and took it out. We think the root canal is curved, right? That is 2D. I just want you to understand how a 3D would look. The video that I'm turning will try and show you how a 3D was looking. It's not as simple as it looks. A 2D is just one curve. 3D goes even in the bucco-palatal, bucco-lingual direction. That's what you should try and visualize, because root canals will be much simpler then. We leave it at that for undergraduate level. Again, if you put the file in the root canal, when you take it out, see, you can see which side it's turning. You only need to work on that side to prepare the root canal. You had words like step back, a step down, or a step back and a crown down. One was conventional preparation. We prepared to whatever sizes. There are other preparations of reciprocations and crown down, and ultrasonics. I'm not going there. What we'll speak about is step back and step down. Step back is what? I've gone to the root end, say size 25, but 20 millimeters length. My working length is 20 millimeters, and I've enlarged till 25. For some reason, there are multiple curvatures, and it is a tight binding canal. I'm getting stuck somewhere in between, and I'm not going to go there equally every time, systematically, serially. For which what we'll do is, we will start removing the restrictive dentine above the apical end. So this was a 20 millimeter length, 20 size, or 25, I said, enlargement size. So I will take a 30 size file, reduce 1 millimeter. So 30 size file at 19. Clean the cavity again, recapsulate, patency filing, everything. Take the next file at 35 at 18 millimeters. Again, clean it well with all those irrigants, hand files, smallest files, apical clearing files, patency files, recurve files, everything. So 20 becomes 19, 19 becomes 18 in length. But what happens? Diameter was 25, becomes 30, becomes 35. When you go to 40, you make 17 millimeters. When you make 45, you make 16 millimeters. You make 50, you make 15 millimeters. That way you're stepping back, which means you're trying to remove all the resistance that you got in the root canal because of any reason to clear your pathway for a better cleaning, for a better obturation and a completion of a root canal. This was the earlier concept. We still follow it. Believe me, we follow it. About 10 or 20% of the times, you still need it. You have no choice. But today, what's very, very popular is what crown down technique is all about. Which means you start from the top. You start with a larger file, a bigger file, a much bigger tapered file. And you know what? We are working on the sides and not the tip. The tip doesn't cut, only the sides cut. And then we'll use a next file to go deeper. Sides cut, a next file to cut, and next file to cut. So it keeps going that way. So what happens at the end of it is, you're only going to the root end with that one file or two files or three files maximum to prepare the root end. So that's a pure crown down technique. Just to revise all what I said, we divide the root into 3/3, the coronal third, the middle third, the apical third. I will use a larger tapered instrument. Just an example, okay? Say 8 taper or 10 taper or 12 taper. It doesn't go anywhere far. It is just on the top, but it opens. When it opens, I can see the next level. I'll take a smaller file than the before, say 6 to 8 tapered file. I'll open the middle. Then I'll use my hand files and go till the root length. I'll make my working length, and then I'll start working on the root end. There I'll use maybe 4 or 6% files. These are only tapers. Then I'll say I'll end at 25, I'll end at 30, I'll end at 40. That becomes the diameter. So length of the root canal is important. Taper is not so important. Diameter is also important. Okay, so understand this concept. This is about root canals. Now when you shape, you do this. So entry, what happens? Coronal flare. Why do you need to flare? You don't need to all the time. If you have a large canal like a front tooth, an anterior, like a canine or a central incisor maxillary, you don't have to. A distal root of a molar, you don't have to. A palatal root of a maxillary molar, you don't have to. Where you need to is all these obstructive, restrictive dentine. Like you see here, this is the point. There are many a times on a mesiobuccal root, it becomes more difficult. That's when you will try and do this. You will use that files to brush it out and remove the restrictive dentine. That's called a pre-flare technique or coronal flare technique. By removing that restrictive dentine, your root canal becomes that much more straighter. For which you have various rotary drills from different companies. Use whatever suits you, whenever suits you. But today you are writing a paper to understand that much. So you need to understand one more thing. How far to go? you have to go till the minor apical diameter. That's the constriction that we have talked about. Because endodontics ends there. Beyond that is a periodontium. It's all about your cementum. It's all about periodontal ligament and the rest. So a simple technique of working length is this way. This is, of course, we have done post shaping because I've taken a 35 size file. We also do 2 times, pre and post. So all what we're doing is we are trying to put a lip clip. There are 2 components in it to complete the circuit. I'm sure you know in working length, right? Then I'm putting a file clip. When you put a file clip, it starts going straight. The file goes in and the reading starts to come. There are a lot of requirements in it, like it has to be a dry tooth but a moist canal, leakage should not be there, rubber dam is a must, and as you go deeper you have to confirm it twice. So I've used the black color gloves just to show you. So I went beyond. It's 0 0. You have to come to 0 0 and then come back and reconfirm it once or twice. Adjust the stopper. That's my working length now, 0 0. I reduce it, go up, and then maybe I come back again just to confirm it. So working length is all about this. There are many ways to do working length, from radiographic technique to mathematical formulas to combinations. This is electronic way. That reading that shows 0 0, transfer it to a scale or an endo block, and you're getting 22 millimeters, 22 point something. That's your working length, right? This you will translate it to every file that you work from here on that goes to the apex. That's how you do the shaping of the tooth. So just quickly, I'll play this one last video. That this video is all about opening an access cavity, complete root canal it is. I'll maybe run it fast. Once you open the root canal, you start cleaning it a little in the chamber. And then you get the files to length, get the working length, if it's possible. And this is how you're using a rotary files. This is from some system of some company. You can follow anyone, but this is how you start enlarging it. So I'm just running it fast. So if you see here, start cleaning in between and running it fast. So if you see, this is one of the second or the third last files I'm enlarging, and then you'll clean it. We're working under the microscope for a front tooth through the crown. There's a case of pulpitis, which is referred, of course, and indicated case that way. And we start irrigating the canal. Right. And then we use a couple of rotary files, maybe 3 files, maybe 4 files. There's also single file systems. If it's a vital tooth, if the diameter is good that you achieved, it's acceptable. There's a technique to work on it. All I'm saying is just follow this, right? Okay, that's about shaping. Following which, you clean it well. And once the cleaning is over, we will dry the root canal with absorbent paper points. After the paper points are placed for about 20 seconds, and then you put the sealer, you put the Garapurchas, do a lateral compaction, and you'll seal it at the entry point. And I'll show you an X-ray and stop this. I've done a down pack and a backfill in this. I don't want to show that for you all now. I'll skip from here. So this is an obturation for us, okay? So I'll leave it at that. So if you want to just see the radiographic picture, when you make a root canal or write a paper, remember this much. There's a preoperative picture that you've taken. There's a working length maybe you'll take. Today we can use apex locators. The working length picture, a master cone picture, and then you have a post-op picture. So there are 4 pictures that you need to make in a root canal preparation. What I am focusing mainly is on biomechanical preparation or the cleaning and shaping. Okay, that was for one of those papers. I think we went a little long there. We'll just talk about another topic. We'll go a little fast here. Same way you construct another paper. If you have a question on bleaching of discolored teeth, in my mind, first, of course, maybe introduction, a definition, a classification, mechanism of bleaching, agents available for bleaching, procedures or protocols for bleaching, treatments of, say, tetracycline or any of the bleaching rather, and of course its conclusion. Definition, of course, cannot be changed. It should be word by word, and I expect you all to write the definition from that particular author. Everybody has a definition. Like in the earlier speakers, when they spoke about different topics, right? Say, suppose cavity preparation. G.V. Black has given a classification, Marzuk has given a classification, or somebody else has given another classification, Student has given another classification. So please follow the same, okay? So when you talk of tooth discoloration, now you know Nathu's classification is one. You have extrinsic or intrinsic. Like I said, these notes, please read from your books that your teachers have given you, or from the best places that you can achieve from. I am not here to give you notes that way. All I'm trying to tell you is, in today's day, I know it's not a nice time for any one of us. But don't worry, in 1911 or 1919, I think there was a Spanish flu pandemic. From then also, people have been graduating. So we all will graduate, you all will graduate, okay? So bleaching agents, you need to understand what are the different types. You should understand one thing. Anything that can liberate oxygen is a bleaching agent, because it's going to liberate oxygen radical, and that's going to bleach the tooth. So start thinking, what are the chemicals that can help you? After all the tests people have done, they've said, okay, hydrogen peroxide can work, sodium perborate can work, carbamide peroxide can work, and there are some over-the-counter products also. Even titanium dioxides and many new materials. I'm not going to go into that because that's about laser bleaching. Now here, what are the procedures? You can classify it in many ways. I leave it to you. You can say in-office bleaching and home bleaching. You can say vital bleaching and non-vital bleaching. You can mix both of them and say in another classification. Everything is accepted. But if there is a way to quote it, do that. That will attract you a little more of weightage on your paper. So intracanal bleaching, of course, you know how it is, why it is. Today, we don't want to sometimes do a crown on the front tooth or a veneer on the front tooth. But having said that, after doing a bleaching for a couple of weeks, now if I know that the tooth is not going to get back to the normal color because it's an old case, the discolored case, the dentin has got all absorbed, then we need to put a veneer. We may have to go for a crown sometimes. That's a different case. But what you need to understand is, first try and bleach the tooth. What happens is in bleaching, I said it's an oxygen release. It helps the tooth to change the color. But if the old case, the penetration of that discolored material, it might be a sealer, it might be bacteria, it might be byproducts, it might be debris, anything that matters. If it's gone into the dentin too deep, it becomes too dark. And you all know enamel is what? It's a transparent structure, a translucent structure. It only drinks the color of the tooth. That's it. So all I want you all to understand is enamel has nothing to do with bleaching. Though we use it on the enamel, what we need to understand is how deep that discoloration has gone. Having said that, that is one of the reasons why I put tetracycline as a different classification, because here most of the time bleaching don't work. In a hypoplasia, it may not work because there are bands, there are pits, there are many other defects. That's when you need to do an abrasion technique, maybe macro, maybe micro. Like sometimes you may have to cover the tooth like a veneer or a crown. You need to see the quality of the tooth structure. So it's very important. So when you get a question on bleaching, understand this much. Start from definition to conclusion. Like I said, you can put more headings. I'm okay with it. But see that you have a content on it, write about it. And to the question asked. If there is only write about bleaching agents, you'll only pick about those. Rest are not important. To the point. And you need to be elaborate. So I'm just going to show you a small video and a clinical case here of how we did bleaching. Bleaching, like I said, should be freshly prepared agent. You have a powder and a liquid, or you have an injectable system. Use a Opel or a Opel dam or a quick dam or a light dam or a gingival dam or a flow dam. So many names are used, okay? In the gum, you see that green color layer? That's nothing but a light cured resin. It's a flowable resin. It is just, instead of putting a full rubber dam sometimes, we may just do this on a white tooth. And then this is a light activated. It's actually laser. So you can light activate a agent. It's a walk-in, walk-out procedure. 1 or 2 sessions. It's a vital tooth bleaching, in office bleaching. You can't do it at home. You need a doctor, a dentist to do it for you, right? So this is how we do it. So see the before, see the after. So I'm just showing show you a picture. See how the before and after is. You can many a times get good shade changes. It's of course a cosmetic procedure, but there are dentists, there are patients asking for it. So you start from here. These teeth are not bad looking at all. And see, we did a bleaching. Again, a blue colored gingival dam, a white colored chemical. Bleaching was done on upper teeth first, then the lower teeth, and then a lot of restrictions, precautions, post-op instructions, all that you read, please. And you see this before and after. It's come bright white, like a chiclet white color. You can't expect it to shade. I know in Prosto you've read about shade guides, like the Vita shade guide. You have A, B, C, D, A1, A2, A3, A3.5, maybe A4 sometimes. And similarly, B1, B2, B3, B4, and C and D, and it goes. You can't expect a D shade to come to A. It did not happen. A3 may become A2, may become A1 sometimes. But don't expect multiple jumps from each of those gradients, okay? Just to know for you all. Okay, let's go to the next topic. We have some other topic or something called as post-endo restorations. In a post-endo restoration, if you ask me, first thing is like, you know what, I want to think about why do I need to do a post-endo restoration? Even before starting a root canal, okay, not after. It's like this, you know, there's something called as a diagnosing a case. I know it's a root canal, but ask my question, next is what? Can I restore the tooth at least to function, if not for cosmetics or aesthetics? If I can do for both, nothing like it. So that's called case selection. So select the case only if it's indicated, please go in for it. So that's about consideration in treating endodontically treated tooth. And then we go in for protecting the remaining coronal tooth structures, restorative treatment planning of non-vital tooth, because it's non-vital root canal treatment has been done, evaluation of tooth or teeth, factors determining the post-selection, and clinical recommendations or considerations. This is what I thought I'll write for this paper. You can write another way also, but a flow chart, like I said, anything can be thought about. So assessment, I told you what it was between diagnosis and case selection. Case selection is important. If the case is not right, it goes out. You go for the next procedure, maybe an implant or a bridge, I don't know. Considerations in treating endodontically treated tooth. What are the considerations? Of course, anatomy. How deep is the curvature? How short is the curvature? How acute? Can I put a post? Can I put a knot? Biological. Does it have a good ratio, crown root ratio? Is there enough bone support? Or mechanical. Will it help me or not? After doing, is there a thing? Or is it going to crack or fracture, or it's not going to help me at all? Protecting the remaining tooth structure. This is a very important point. Most of us fight to get it all the time. It's nothing but a resistance form of a cavity. We have forms like outline form, retention form, resistance form, convenience form, and then it goes on. We forget actually. Last is toileting of the cavity, right? So the resistance form is this. Feruling is nothing but encompassing the tooth with the cover structure. It might be a tooth ferrule or a core ferrule or a crown ferrule, whatever it is, that you can decide on the tooth remaining. But you need to put something on top to cover it. That's how you help tooth and the processes together. Restorative treatment planning of non-vital tooth. Why I put core here is core is 100%. Every root canal you open, you need to close. And that's called the core built up. Post may not be every time. You don't need a post. If there are good tooth structure, the strongest portion of the teeth, I say, you know, like what are they? Say oblique ridge, say marginal ridge, transverse ridge, cusp tips, or cingulum. If these are intact for any reason or all reasons, then don't need to put a post. Don't have to destroy the tooth. Just close it with a core built up. It's enough. So evaluate the tooth well. Once you evaluated it well, okay, core materials. There are so many core materials. You have a composite material, you have amalgams, which has been covered earlier lectures. I saw that. You have cast gold, you have onlays, you have endo crowns, you have inlay onlay type of materials, and you have a full crown. Anything is possible. Slowly, of course, we are doing less of full crowns, coming to endo crowns more, okay? Evaluation of teeth. Anterior teeth have got different evaluation, posterior different. You know why? Structure and the make and the positions. Behind we use it for chewing. You need strong. If a person's masseter is developed well, you know his teeth are going to get flatter soon. He's going to lose his vertical height of the face. The canine guided occlusion. It's going to be a groove function. The incisal guidance. These things go away. So you need to understand these things. So of course, this will be a little bit of prosthodontics now. So evaluation of teeth is important before going to the next step. You also have something called as factors determining post selection. So what are they? Of course, very classical in every book it gives. I'm sorry. It goes like this. It says about factors determining is what? Post length, diameter, it can be width, that's called diameter, anatomy, configurations, design of the post, and also, of course, the luting cements and so on and so forth, right? So here I'm going to play a video just to show you different posts that we have used, okay? You can see a steel post, a metal post, a fiber post, a cast post, a corbel tops, different things we have done this. So I'm just showing you this much, just to show you a small glimpse of different procedures that have been done. All these we are doing. Believe me, endodontics is being so interesting. Dentistry is being so interesting in these days because we've got excellent material that we're using. These are fibers we've used on this patient. The fiber post build-ups, one of my favorites, right? But never ever use something that's active in the canal, that is something that is threaded in the canal. I want something that's passive, parallel tapered maybe. So no screw post, please. Screw posts are disastrous. They're all gone. They come in gold and silver color, and all. They're not nothing to do with the color because they're not gold. They're only colored. Okay, they rust. They corrode. Cast post, yes. A badly broken down tooth where you have no crown root ratio, where you have no enough height of the tooth for your axial wall, then maybe yes. So this is one example of cast post. GPs were removed up to the straight part of the canal, and then the posts were fabricated, tried in the model, and then put in the patient's mouth for a trial, and then cemented maybe. So this is how it comes. Okay, this is a case of cast post. Now I'm going to play your video on a fiber post. Fiber post, just for you all to understand what it means. It reinforces the crown and the root ratio because we spoke about the length, the diameter, the taper, the fit, the cementation media, the surface texture, many reasons. They all are covered in theory. This is one system that we followed. Now there's a broken tooth here. You see there's a lateral incisor that's broken. For this lateral incisor, we're trying to put a post. So we try to put a rubber dam first, which is very important. Isolate the tooth first, of course, especially in these times where you don't want to come in contact with saliva. Put a opal dam or a blue color dam or a white color dam for a sealing. Once it's sealed, then you've done a floss tie technique also here. You'll take a drill to remove the GP point to create the space. A micromotor drill and a post drill. Isometric post is what we've done in this case. Why I'm playing these videos or clinical picture is when you read your theory, if you can correlate this that you had seen it somewhere, I think it becomes that much more easy to reproduce. At least that's true for me, So that's why I said, okay, I asked Abrar when I spoke to him, to Dr. Abrar, you know what? I don't want to go theoretical way to show. I have all the presentations in me here to show you a theory and bore you. And at the end of the day, when you heard for 4 hours, I don't think you'll be interested to see a lot of theory also. So that was the fiber, you see. That's a newer post that we're using now. It's a glass fiber post. We took a post there. I'm not going to go into the theory. We have to have a bond. See, now to bring them together, you have to condition. One part is the tooth. One is the post, right? How do you condition the tooth? You etch the tooth, you wash the tooth, and you dry the tooth. On the other side, you have a fiber post or a metal post. You have to cement it, luting it. In resin chemistry, when it's resin, you need to bond the post also with the luting, with the cement, the resin bonding agent. Or sometimes you use a silent coupling agent. So that's what we're doing. Conditioning the tooth here. It's a total etch technique. A phosphoric acid. Wash the tooth nicely. Of course, I'm activating nicely. with a probe there, going to the full length, very deep. I wash it with the regular distilled water. You can use a 3-way, it splashes everywhere. So I prefer a syringe. Lots of water, copious amount of water. And once that is done, you dry the canal because you want to put a bonding agent now. A dentine bonding agent is chosen. If you saw there, I made a dentine bonding agent. That was, I converted a light cure into a dual cure there by using an activator. That's what a video showed you. But as students, you just write it as a dual cure dentine bonding agent that can go to the deepest layer and self cure also and so on. Once you apply the bonding agent, you throw air. It's called air thinning, blow drying to move it everywhere and remove excess. Also use absorbent points to remove excess. Now the tooth is ready. The post was ready there previously because one of my associate doctors or assistants have cleaned it up and kept the post ready. At this time, I will take an injectable material, a light cure it, of course, first. That's because it will light cure the tooth, sometimes even the post material. This is a core flowable material that we're using, like a luting cement. It's a 2-in-1 and a core built up. With the thin tip, take it straight into the deepest portion of the root canal. This way, deposit it, and then withdraw the syringe out so that you get no air bubbles as much. Take the post and do a pumping, like how you do cone pumping in Gadaparcha. That's how you do a pumping and let the excess cement escape out. And then you have to put a matrix band and build it up. This is a broken down tooth, so I use a different type of a core form to build it up. So you light cure it buccal and lingual also. More light cure is always better. So occlusal, buccal, lingual, you saw here. That's what you will do for all the other cavities, even in vital tooth, even if it's a simple restoration. Once the light curing is done, I fill that remaining material in a core form. I would say if the tooth is good, just use the band, matrix band, it's enough. This was broken down tooth. Take it into on the tooth, under pressure. Press it tightly, remove the excess, and then you light cure it. Occlusally, buccally, and also palatally. Once that's complete, you can remove the cover out or cut it out because I didn't have a matrix band here. I use a core form. And then you do the tooth preparations. You remove the excess out there. And this is how you will build up a badly broken down tooth. You see the picture now, you have a tooth built up done. It's a crown prep done sort of for a ready crown that can be placed. So that's how you should do it, okay? Okay, we'll go to another question. 2 more to go, but now I won't show you the pictures or videos. I'll just speak a little about it. Endo-perio, if the question is endo-perio interrelationship or any other relationship on endo-perio, I would write on etiology, pathway first, etiology next, the difference between them, the etiopathogenesis, the classification, clinical features, treatment plan, and then conclude it. So when you ask me about pulpo-periodontal pathways, there are so many classifications given by many people, you know. If you say you can talk about Franklin Wayne's classification, Glickman's classification, Stock and Gulabiwala's classification, or any other classification like Grossman's classification, whatever you want to. But for a simple understanding, I want to say this way, you know, as a student, you understand this much. You have a tooth and you have a periodontium. Periodontium consists of 2 hard and 2 soft structures. You have a bone, alveolar bone, you have a cementum, you have a PDL, and then what happens, they're connected to each other, right? When they're connected to each other, and gingiva, of course. When they're connected to each other, what happens is there is a communication in many ways with blood supply and nerve supply. For a blood and nerve to go, there may be portals of exit, which might be in the form of a main canal, additional canal, accessory canal, lateral canal, developmental defects, incomplete reunion, whatever they may be. So understand this much. So if you have to simply know how all can it connect, a tooth may be simply involved because of a decay, or a caries or a fracture, occlusion load, whatever it is, you may call it as primary endo lesion. A tooth is involved and only endo is involved. It might be a pulpitis to apical periodontitis, but it's primarily endo. Now the patient can go through it, the pain and the swelling or whatever it is, and still not come to you. It will spread in the bone. Then it becomes what? Primary endo, because it started from endo, it went to perio now, because it involved all the other structures around it, the supporting structures like the foundation. The first classification was primary endo, now it became primary endo but secondary perio, second classification. Sometimes there are no problems, patients are not well to do, or they're not well to do, they don't maintain well, and they have pockets and whatnot. And in that pocket, it might be just a perio problem. Just treat that much. That's the third classification according to a clinical classification, primary perio. But if the patient has not taken care of it well, not come to the doctor on time, the perio pocket has gone so deep from the furcation till the root and become a communication. It becomes primary perio and secondary endo. That's the fourth classification. Sometimes you may have a patient where there is endo involvement and perio involvement and combined involvement, both involvement. What came first, even we don't know, because patient comes so late. So that's different thing. So that's all about it. So primary endo, primary perio, primary endo, secondary perio, primary perio, secondary endo, and last is true combined. So that's a classification you need to know. So pathways of communication starts from them, from pulpal to periodontal. And you also have the differences here. You need to understand, to know the differences, you need to understand these points. I'm sure you can read your books, the notes that you have with you. What's the etiology? Why the pain is calm? Is the pain sharp? Then it's endo. If it's dull, it's perio. If there's a swelling, is it apical or is it near the starting point of the gingiva? Percussion, when you percuss on top, it is morely endo. When you percuss on the side, it's morely perio. But don't percuss with a probe or an instrument, please. Finger is enough. The patient is already symptomatic. When you press, they will say yes, okay. Probing, pocket depth, all that can be probed. Sinus tracing, when you put a GP point in the buccal sinus or lingual sinus or the palatal sinus, you just cone pump it slightly and take it to the full length. The GP point will go and curl around the cause. Otherwise, the sinus doesn't come. That sinus tracing will tell you, is it endo or perio? Because it might be too apically or too coronally. You decide that. Mobility, it might be a class 1 or a type 1 to type 2 to type 3. It might be endomobility, which goes away actually in pulpitis cases, in abscess cases, not mainly pulpitis abscess, alveolar abscess, acute, it comes up, or it might be another cause altogether. But if it is a perio cause which has a mobility, the prognosis is guarded. Then you have the etiopathogenesis. Again, anatomic considerations, etiological considerations, contributing factors. Like I said, classifications, Simons, Olives, and Pollocks. You take what you want, it's okay. One of the last topics I'll discuss now in 2 minutes is traumatic injuries. One of my favorite topic, interesting topic, and the most needed, because this is very sad when it happens. Because unfortunately, most of the patients cannot reach the dental office on time. And we end up losing the tooth in a matter of time, sooner or later. So if somebody can go deep into that, I know pedo, I know there are traumatic involved agencies and organizations, but this is a very sad thing. Anyway, when you get a question like this, what's the cause, what's the incidence, what's the classification, the terminologies, the management of traumatic injuries, involving pulp, not involving pulp. If it is not involving pulp, it becomes conservative, like before class 3s or type 3s. If it is involving, it becomes to endodontics. The entire classification of LEs will go that side. So you follow one classification. You can follow any, whatever you deem fit. Last is conclusion. Okay, that's how you do it. So these are the few topics that I thought I'll discuss. So terminologies, what do you want to write? You will write about all these terminologies. What are craze lines, cuspal fractures, cracked tooth, split tooth, vertical fractures, or when you talk of classifications, they can be anything like this, Ellis-Davy or Anderson's. Anderson is a big name, of course. You can see whatever it is. Conservative management. Is it just, I said conservative management, so it's before third classification. So it's only in the enamel or enamel and dentine only, not involving pulp. So you can restore them many times. May put semi-permanent restorations with a liner, with a pulp capping, and then go for permanent. Both are okay. So that's how we go it. Look at the features. Always when you want to decide and define your diagnosis, you need to have a clinical picture, a radiographic picture with the patient history, bring them together, then come to a conclusion for a treatment plan. But the most important thing in any treatment you have to write in a paper is follow up. If you write follow up for every procedure, it's okay. There's nothing wrong. That's more important. We don't follow up sometimes. Okay, that's important. So as I conclude, what I want to tell you all as young, budding, soon-to-be graduates. When you read and read. You read why, to remember. To remember, when I told you something, you need to know how you can repeat it. When you read something, can you repeat it? When you read something, can you repeat it and recollect it? When I read something, now just we saw traumatic injuries. If somebody is very smart with their cognitive skills are great, they would have had the picture in their mind already. I had some classmates with me who are very, very smart. One scene, it's a photo capture. I can't get that. I need to read. I need to read again. Once I read, I may have to repeat what I've read. And what I've repeated, can I recollect in my mind? And if I can do that, read, repeat, recollect, and then reproduce in the form of speaking it out or writing it out. If you can come to this level, right, I think things will become very, very easy. I think with this, I'd like to thank the team of MUHS who have invited me to speak on few topics to help you